Hi, this is Katrina Wu, and this week we'll be talking about the menstrual cycle. And I have to say, I think this is one of my very favorite topics in midwifery. You will use this content all the time, whether it's just helping women understand how their body works every month, or you're explaining how hormonal birth control works. You're going to be explaining this content and using this content a lot. So this initial slide here is really the outline for the rest of this presentation. So I'm just going to give you a brief overview of everything on this slide, and then we'll get into each of these rows in a little bit more detail. So up at the top, you see we have a follicle. And when you think about ovulation dividing the month in half, you can think of that first half as being the follicular phase when we're talking about ovaries, and the second half being the luteal phase. So at the beginning, you can see that we're recruiting follicles, and then one follicle ends up being dominant and becomes the mature follicle. And then you see that the ovum is then released. And then what's left of that follicle becomes the corpus luteum, and that gets big, and then it starts to degenerate, and then it basically absorbs back into the ovary. So now let's take a look at what our hormones are doing during that time. So you can see on the hormone level here, so FSH, or follicle stimulating hormone, is this red line, and you can see that it's increasing during the follicular phase, and it's released by the anterior pituitary gland, and it triggers follicles to grow. So that's encouraging follicular growth, and then in turn, the follicles that are growing start releasing estrogen, or estradiol. So that's the blue line here. So you can see that in the follicular phase, estrogen, as those follicles start to grow, starts going up. And then estrogen peaking is what prompts LH to be released from the anterior pituitary gland, or the luteinizing hormone. And when LH is released, then about 36 to 40 hours later, that's going to prompt ovulation. After the egg has been released, there is still some estrogen being produced by follicles throughout the luteal phase. However, the corpus luteum, which is the follicle that ultimately released the egg, that's going to start producing progesterone. So while estrogen was dominant in our follicular phase, progesterone will be dominant in our luteal phase. So when considering our ovarian cycle, we have our follicular phase, followed by ovulation, followed by the luteal phase. And then when we consider our endometrial cycle, or uterine cycle, we've got the proliferative phase, followed by ovulation, followed by the secretory phase. So let's look at what the endometrium is doing during this timing. So from about days 1 to 5, that's when a person is having their period or menses. And then you can see as estrogen starts to build, that's when we start building up the lining again. So estrogen is what's prompting endometrial growth. So ovulation happens, and then it continues to build. We continue to have estrogen, so that continues to prompt growth. And now we also have progesterone. Progesterone is going to bring more blood flow to the endometrial lining and make those uterine arteries more spiraled and coiled to be able to support the blood flow needed for a placenta should implantation happen. So that's our quick overview. Okay, so let's start by talking about menstrual cycle hormones. So our pituitary hormones are going to be FSH and LH released from the anterior pituitary gland, and then our steroid hormones will be estrogen and progesterone. And they're released by our ovaries. Estrogen's released by the growing follicles, and progesterone's released by the corpus luteum. So let's look at the diagram here on the left. So we have the hypothalamus in the brain, and that's going to release GnRH, or gonadotropin releasing hormone. Gonadotropin releasing hormone is going to act on the anterior pituitary gland to release both LH and FSH. LH and FSH both act on the ovaries. LH acts on the thecal cells, while FSH is acting on the granulosa cells of the ovary. Those in turn will cause progesterone and estrogen to be made. And just as a side note, your textbook is British, and so if you see oestrogen or oestradiol, that means estrogen, and the British spelling just includes an O, so you can just ignore that when you're seeing that in your text. If you're writing, you can just write estradiol or estrogen. So then progesterone and estrogen create a negative feedback loop, causing less gonadotropin-releasing hormone to be released. So as estrogen begins to build up and increase, FSH is decreased. So initially, FSH is being released and it's causing follicles to grow. And as they grow, those follicles form more and more FSH receptors on their surface. So pretty soon you have some follicles that are bigger than the others, and they're really absorbing the vast majority of the FSH, while the smaller follicles essentially die off because all the FSH is being used by those larger follicles. The small ones can't compete with the larger follicles that have a lot of FSH receptors. So that's an example of a positive feedback loop within this system, in that the more receptors you have, then the more FSH you're able to absorb. But as some of those follicles get bigger and bigger, they start to be able to make estrogen. And as estrogen is released, it travels through the blood system, goes to the hypothalamus, and says, hey, slow down on making GnRH. So FSH prompts follicular growth, but then those larger follicles start making estrogen that then says slow down on making FSH, and then less and less FSH starts to be released because of all the estrogen in the system. So that's a negative feedback loop. The result of this decreased FSH is essentially that those small follicles really do just die off, whereas the larger follicles do still have some FSH coming towards them, and they're able to continue to grow to maturity. So that's our first reminder here at the bottom. Increased estrogen leads to decreased FSH. And you can see that in our graph. As the red line of FSH starts to pop up, then estrogen starts to be made, and in turn, FSH starts to drop. So now, looking at estrogen, we can see that estrogen's climbing. That blue line is going up, 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 up in the follicular phase, and when it reaches its peak, that's going to prompt LH to be released. So estrogen has a negative feedback loop with FSH, but it's a positive feedback loop with LH, in that as it peaks, that's going to prompt LH to be released. And then when LH is released, that's going to in turn prompt estrogen to begin to dip. And then we see that shortly after that is ovulation. That's the gray lateral line. And then the follicle that released the egg really switches gears. Think of it as a rewiring. While there's still some of the smaller follicles that may still continue to release a little bit of estrogen, that corpus luteum, where that egg had initially ovulated from, is going to start producing a lot of progesterone. So that's our second big takeaway line here. LH surge leads to increased progesterone and decreased estrogen. So now the luteal phase is when the body has the potential to become pregnant. So both estrogen and progesterone travel to the hypothalamus and the anterior pituitary gland, and those high levels in both are saying, hey, we might have a baby coming. We don't need to release FSH. We don't need to release LH. You can just chill for right now. So that's a negative feedback loop of estrogen and progesterone being high to say we are anticipating potentially having a baby, so don't release FSH. And really, that's how birth control works. By having high progesterone and estrogen, it's sending a message to the brain that we don't need to be releasing FSH to grow and ultimately release a follicle, or an egg, I should say. So that's our third line here. Increased progesterone and estrogen lead to decreased FSH and LH. And then finally, if there is no pregnancy, that corpus luteum is going to start to shrivel up and release less and less progesterone. And that dipping progesterone is what's going to then prompt the hypothalamus to release more GnRH, which will then release more FSH, and we can start the cycle again with beginning to grow more follicles. So again, that's our final line. No pregnancy leads to decreasing progesterone, which leads to increasing GnRH to start again. So now I'd like to say a word on cycle lengths. So if you have a 28-day cycle, then it's pretty typical that you're going to ovulate on day 14. However, if you have a 30-day cycle, it might be intuitive that you would ovulate on day 15, but actually that's not very typical. Variations in cycle length almost always are occurring in the follicular phase. I want you to think of that corpus luteum as essentially having a 14-day expiration date. So once the egg is released, that corpus luteum will be releasing progesterone, and then it will peak, and then if there's not a pregnancy, it will start to dip, and that progesterone will go down. And then as it's expiring, that's what's going to release GnRH to start again. That dipping progesterone is then what's going to prompt menses. So while there can be variation by a day or 2 or even 3 from woman to woman, you can expect that if you have a shorter or a longer cycle, you're still going to keep around a 14-day luteal phase. And that's important when you're timing pregnancy avoidance as well as when your patients are coming to you for help with getting pregnant. What's fascinating, though, is that if you do have a pregnancy, instead of progesterone dipping off, the baby is going to send HCG into mom's bloodstream. HCG is what we use to detect pregnancy in pregnancy tests. That HCG will travel to the ovaries, and that HCG basically signals saying, hey, I'm here, don't have a period. And because of that, the corpus luteum will actually maintain releasing progesterone for typically about 10 to 12 weeks. So normally in pregnancy, we're relying on the placenta to be releasing progesterone in order to maintain the pregnancy. But at the beginning of a pregnancy, the placenta isn't well established yet, so that corpus luteum will just continue to release progesterone rather than expiring after 14 days. That 10 to 12 week mark is actually when we will typically see HCG begin to drop off because it's not really needed anymore. It's used to tell the ovaries, hey, keep making progesterone. And once the placenta can take over and the ovaries aren't needed anymore to make progesterone, then HCG is really not needed either. So I know we've already touched on follicular development a little bit, but let's just get a little bit more in depth. So this process starts with primordial follicles, which you can see in kind of the center top part of this ovary. Primordial follicles are typically recruited actually 3 months before the cycle where a woman might end up ovulating from that primordial follicle. So primordial follicles basically become primary follicles once they begin to absorb the FSH and begin to grow. And then primary follicles can turn into secondary follicles if they get enough FSH and they're growing. And at that point, in any given cycle, there's typically about 15 to 20 secondary follicles. And they're all competing, each containing an oocyte, to see which one is going to be able to be the one to ovulate. So then those secondary follicles are making more and more receptors for FSH, and they're growing and growing. And then some of the smaller ones start to die off because those bigger ones are absorbing the majority of the FSH. And then we get to the point where we have one dominant follicle, also known as the Graafian follicle. That's the one that's going to get to ovulate. Now, something I find really fascinating is that your ovaries tend to take turns. So you'll ovulate from one side 1 month and then the other side the next month. And it might not be exactly every other, but it pretty much is every other. So in any given month, it's really just one side that's doing the majority of this work. Now, say a woman had to have a surgery that, say, it removed one of her fallopian tubes, but the surgeon still left 2 ovaries in her body, then that would essentially cut her fertility in half because it would only be the months where the ovary that had an accessible fallopian tube ovulated that she would have a chance at pregnancy. So the egg would be released, but there wouldn't be a fallopian tube to take that egg and bring it to the uterus. However, if when the surgeon removes the fallopian tube, they also remove that ovary, so she only has 1 ovary in her body, then that ovary will make an egg every month. So where are these oocytes coming from before they reach the point of being primordial follicles? Well, a female fetus at 20 weeks gestation has all her oocytes, about 10 million. And then by the time that fetus is born, it's gone from 10 million down to only a quarter or a half of that. And by the time she reaches puberty, it's already down to 200,000, which I just find fascinating. The most dominant thought is that you're born with the oocytes you have for your life. There is some research to suggest that it might be possible to make more oocytes later in life, but that's definitely not the prevailing thought at this point. So let's take a minute to look at that Graafian follicle just a little bit closer. Along the whole outer edge of it are thecal cells, and then the rest of it is comprised of granulosa cells. There are cells directly surrounding where you can see the oocyte. Those are also granulosa cells. That's what will become the corona radiata after ovulation. So the thecal cells along the outside of the follicle have LH receptors, and they're also the ones that make androgen. So the theca cells make the androgens, which are then absorbed by the granulosa cells, and the granulosa cells, through aromatase, convert the androgens into estrogen. And it's the granulosa cells that have the FSH receptors. So then after ovulation, under the influence of LH, that's going to guide the follicle to begin making progesterone instead of estrogen. So it'll still continue to make some estrogen, but progesterone becomes dominant at that point. And while the granulosa cells were the ones making estrogen, it's the theca cells that are making the progesterone. And then as our corpus luteum degenerates, that corpus luteum becomes a corpus albicans. And corpus luteum just means yellow body, and corpus albicans means white body. And in this upper right picture, you can actually see a very large corpus luteum. So that whole, it's about a third the size of this ovary. So that whole picture is an ovary, and that upper third is yellow. That's the corpus luteum. And you can see it's so much bigger in comparison to the rest of the ovary. You can see how progesterone is becoming dominant. And then you can see a couple corpus albicans probably from previous cycles that are just slowly degenerating. But in that bottom right corner, you can see a little corpus albicans. This is a 46-year-old ovary. The woman had it removed and a picture was taken of it. So she must have been in her luteal phase when she had the surgery. The corpus albicans usually takes about 2-3 months to fully fade away. And then it also typically will leave just a little bit of a scar. Ovulation, where the oocyte bursts out of the ovary, also tends to leave just a little bit of a scar. And then in light of that, I think it's really interesting to think about how we as a society of women are ovulating far more than the women who came before us. The primary societal factors for that are delayed fertility, so women waiting longer before starting families. And then they're typically not breastfeeding for as long, and they're typically having fewer children too. So over the course of their life, they're ovulating a lot more. And each of the times they're ovulating, and as that corpus luteum becomes a corpus albicans and ultimately leaves that little bit of a scar, those two sources of scarring mean that as women in today's society, we have more scarring on our ovaries, and that can play a role in ovarian cancer risk. So interestingly enough, women who are on hormonal birth control for an extended period of time have a reduced risk for ovarian cancer because they're not ovulating. It's essentially giving their ovaries a break, the same way pregnancy might. Okay, so a few more pieces of information about ovulation. So we've already said ovulation occurs about 36 to 40 hours after the LH surge, and then that oocyte or egg is only viable for 24 hours following ovulation. So that really is a short window. In contrast, sperm, if we're trying to avoid pregnancy, we like to say that sperm lives for 7 days, whereas if we're trying to get pregnant, then we say it lives for 5 days. So in comparison, it lives quite a bit longer. So then if we're providing fertility counseling for somebody wanting to get pregnant, we would want to recommend that they're having sex prior to the point where they would ovulate so that there's already sperm up there waiting. If it's only going to live for a day, then we want sperm already up there waiting, or it might not get there in time. Some women actually report being able to feel ovulation. It feels like a pinching sensation or a little bit of pain on one side, and that's known as Mittelschmerz. There's your vocabulary word for the day. You can counsel women to use ovulation predictor kits. Some women find that helpful when they're trying for a pregnancy, and those can come as easy as just seeing a smiley face for when you have that LH surge, or they can be used where you can see how dark the line is. So if they're doing one where it's just a control line and a test line, they can gauge it based on the degree of darkness to have a sense of when they're most likely surging. And then again, you're wanting to time ovulation for being about 36 hours after that point. So women's bodies produce 3 different types of estrogens. So it's E1, E2, and E3. E2 is estradiol, and that's the primary dominant estrogen that we see in our menstrual cycles. Of the 3, it is the strongest. Now, all 3 of them are produced all the time throughout a woman's life, but it's just a matter of which one is most dominant. So estradiol, or E2, is the one that's most dominant in women's reproductive years. And then we have estriol, or E3. That's the primary or dominant estrogen that's produced by the placenta. And of the 3, it's the weakest. And lastly, estrone, or E1, is the dominant estrogen that's produced during menopause. And I don't particularly like the connotation of this mnemonic, but in case it helps you, estrone rhymes with crone. So estradiol, estriol, and estrone are our 3 estrogens. What effects does estrogen have on the body? Estrogen makes things bigger. Whether we're talking about growing the endometrial lining or breast tissue development, estrogen means growth. It's responsible for secondary sex characteristics in females. It increases blood flow, especially to the surface of your skin. So estrogen is what's credited with causing like a soft, glowy skin complexion. Estrogen also encourages fallopian tube peristalsis, so it's helping prepare the body to get pregnant. It's in that first half of the cycle, and it's getting the fallopian tubes ready to receive an egg. It softens and opens the cervix, again in preparation for getting pregnant. It happens to depress appetite, and then lastly, it stimulates growth of lactobacillus in the vagina. Estrogen is responsible for the fertile mucus that the cervix produces in gearing up for pregnancy. So fertile mucus is really high in glycogen, and lactobacillus like to eat the glycogen. So that's partly why it helps to prompt the growth of lactobacillus in the vagina. Lactobacillus is the primary healthy bacteria that we want to take over in the vagina, that we want to be dominant, that helps promote vaginal health. Lactobacillus gives off lactic acid as a byproduct that makes the vagina more acidic, and so that helps to ward off growth of other kinds of bacteria that we wouldn't want to take over. So moving on to progesterone, you can see at the bottom of my slide here, I've got estrogen makes things big, progesterone makes things juicy. That's not entirely true in every way, but it does work pretty well for most things and helps you to potentially keep them separate in your head for what's doing what. So in the first half of the cycle, estrogen has built up that endometrial lining and starts to get some of the vessel growth going, and then progesterone really runs with that. So it stimulates gland and vessel growth and helps make those arteries really spiral and full and juicy in the endometrium. And that's exactly what we want to prepare the endometrium for a possible implantation so that it can develop a good, strong, healthy placenta. And then it does the same thing in breast tissue. So estrogen helps make breast tissue bigger, whereas progesterone gets it ready to be able to make milk. So progesterone's very high in pregnancy. That's the primary place where this role of progesterone would kick in. But it's attributed to breast lobules and alveoli growth in pregnancy in preparation for lactation. Progesterone also relaxes smooth muscle tone, also known as quiescence when we're talking about the uterus. So especially in early pregnancy, we need a good amount of progesterone on board because that helps keep the uterus quiet so it's not contracting, and that's protective against miscarriage. So estrogen's doing things to help get you ready to get pregnant, and then progesterone is not focused on that anymore. We've already ovulated. That ship has sailed. So it's about supporting a pregnancy or preventing a new kind of pregnancy from being initiated. So from that sense, it's making the fallopian tubes quieter, but that's fine because we don't have an egg coming anymore for the fallopian tubes. And then it also makes the intestines quieter or relaxes smooth muscle. So it slows down the intestines, which can make women constipated in the second half of their cycle as well as in pregnancy. So progesterone is considered the star of that show. Similarly, sometimes when progesterone is starting to dip just before menses starts, women will report having looser stools, and that's because the progesterone is dipping fast, kind of causing the opposite effect of intestines picking back up again and moving faster again. So that increased transit time in the intestines. Progesterone also can increase appetite, can worsen acne, altered mood, sodium retention or bloating, weight gain. So these things are more associated with the luteal phase when you think about PMS leading up to menses. And certainly estrogen can be responsible for these too, but progesterone more so. And it's not always about is one hormone high or is the other hormone high. Sometimes it's the ratio between the two. And keep in mind that the luteal phase does still have estrogen being produced. But all the same, progesterone more so is tied with these symptoms. It also causes the cervix to contract and tighten. So that's going to make you less likely to get pregnant. Or if you do have a pregnancy, then that tightening of the cervix is going to keep that baby a little bit more protected because we don't need anything going up into the cervix when we're in a luteal phase or when we're pregnant. So that keeps that environment beyond the cervix more sterile. And then it also makes cervical mucus thick and tacky, again, because we don't need to encourage sperm to go up into the uterus. So estrogen's helping prepare the body to get pregnant, and progesterone really is preventing it. It's not a phase in the cycle that is conducive to getting pregnant. It's either already there or there's no point in trying. And in that same way, the high levels of progesterone in birth control keep the body in this state where the cervical mucus is thick and tacky and the cervix is contracted and tight. It's not conducive for getting pregnant. And then lastly, it increases the basal body temperature. So progesterone has a warming effect, and that's why we see the increase in the basal body temperature that is sometimes used for tracking fertility. Okay, so going back through this cycle again, but looking at the uterine cycle, we want to start with the endometrium. So in the proliferative phase, the first half of the cycle, it starts out with menstruation, and then estrogen is dominant, and it's stimulating the endometrium to proliferate, and you start to see angiogenesis, which means new spiral arteries and veins are developing. And you also see significant growth. So it starts out at about 0.5 millimeter, and then it goes all the way up to 5 millimeters. And then with progesterone, we see continued spiral artery growth and dilated endometrial glands. So they're full of nutrients that are ready for the zygote should there be an implantation. So be sure you're ready to distinguish between the ovarian cycle that we would call the follicular phase and the luteal phase. And then in contrast to that, or overlapping with that, we have the uterine cycle, where we would refer to the first half as the proliferative phase and the second half as the secretory phase. Think secretory like secreting glands, so the juicy side of progesterone that can help you remember. And proliferative like proliferative growth, that's where estrogen's growing up that lining. So a quick note on menstruation. Cycle length is typically 21 to 35 days. Duration is 2 to 7 days, and then typical blood loss is 35 to 50 milliliters. And when our patients use menstrual cups, that actually means that they might be able to come in and give us more concrete numbers for how much blood loss they have, rather than us trying to navigate how often they're changing tampons and pads, and are they super tampons, and that kind of conversation can be tricky. So consider that with menstrual cups, if that might be a helpful tool in your practice. So what causes menstruation? Well, one thought is tissue necrosis or destruction. So the thought here is that as progesterone starts to dip with the corpus luteum destruction towards the end of the cycle, that makes the endometrial lining shorten some, and those spiral coiled arteries start to coil even more to the point where they're kind of kinking off the blood flow. And that can lead to ischemia and then necrosis. So that's been one suggestion. The other suggestion is that it might be an inflammatory process. So with that one, the thought is that the withdrawal of progesterone leads to prostaglandin release. So the spiral arteries are releasing prostaglandins that lead to rhythmic contractions. And then the thought is that those contractions with the spiral arteries rocking back and forth can lead them to break off and slough off as a menses. So thankfully, what directly follows menses is estrogen starting to be built up again by those growing follicles. And estrogen is so good for wound healing. So that's helpful for preparing the endometrium to grow again. So cervical mucus. Cervical mucus is really thick and tacky when women aren't fertile, so particularly in the second half of the cycle, and then also in the beginning of the cycle, but then it starts to shift to be more fertile leading up to ovulation. And that fertility piece needs to kick in sooner than ovulation, and that's what estrogen's doing, is getting it ready, because it wants to be able to pull sperm up and into the uterus ahead of time so that it can be waiting in the fallopian tubes. So fertile mucus is long, thin, stretchy, white to clear, looks a lot like an egg white, and it's also known as spin barket mucus. And this is the main way a lot of our hormonal birth control works, is it's high in progesterone, and so it just keeps that cervical mucus thick and tacky, so sperm wouldn't be able to swim up. So basal body temperatures, basically this is just using a thermometer that has 2 decimal points. So it's able to determine more fine level tuned temperature. So women would just take their temperature first thing in the morning and track that throughout the month. So you can see here on your x-axis, this is just days of the month. And then it's right around 14 to 18, somewhere in there where we're seeing that leap. That means that she's ovulated. And basal body temperatures are really only so helpful. I mean, they're helpful in understanding what your cycle's typically doing from month to month, but they're not that helpful for preventing pregnancy or trying to get pregnant, because they don't tell you when you're about to ovulate. They tell you when you've already ovulated. So you can't really use it to try to time sex. But maybe before tracking, a woman thought that she was consistently ovulating around day 14, and in tracking her basal body temperatures for a few months, she realizes actually I think it's more like day 16, 17. I personally think LH predictor kits, you can get like a pack of 30 for not very much off of Amazon, and just do the ovulation predictor LH kits. And those would be more predictive rather than reactive, and can also give women a good idea of when they're ovulating each month. So once progesterone is being released, it's going to increase her basal body temperature. So that's a wrap. I would really encourage you to watch this lecture as many times as you need to. Slow it down, speed it up, listen while you're doing the dishes. I think repetition really helps for this content. Find somebody who wants to learn this. I feel like all of you probably know at least a few people in your life who want to learn this material, even if they don't want to be midwives. Teach them about their menstrual cycles. The more you can be hearing it repetitively and talking about it, that'll help solidify this content. I'd also encourage you to just get a blank sheet of paper and graph out the follicular phase, the basal body temperature, what each of the hormones is doing each month, what the endometrium is doing each month. Like, recreate this graph as a way to deepen and solidify your learning around this content. So good luck, and let me know if you have any questions. Have a good week, everyone.